Our next speaker is Dr. Christopher Recklitis, who's Director of Research and Support Services for the Perini Family Survivors Center at Dana-Farber and Associate Professor of Pediatrics at Harvard Medical School. He completed a doctoral degree in clinical psychology at Boston University and a master's in public health at the Harvard School of Public Health. Since 1987, Christopher has provided clinical care to cancer survivors at the Dana-Farber Cancer Institute and conducted research to better understand mental health needs. His research focuses on understanding the psychological late effects of cancer, the development of screening measures for detecting distress, and methods for encouraging health-promoting behaviors in cancer survivors. His work has been supported by grants from the National Cancer Institute, American Foundation for the Prevention of Suicide, the Childhood Brain Tumor Foundation, and the Prevent Cancer Foundation. I've heard Christopher speak at least 4 times. I've learned something every time, and I know you will too. Dr. Recklitis.
Thank you, Jay, for that very kind introduction and for inviting me to be here today. It is really an honor, privilege to be here amongst such a large group of people and to have a few moments to talk about some of the late effects that I see and talk a lot about with survivors in our clinic. So my charge today is to talk about fatigue and insomnia after cancer. These are big topics, so I'm obviously not going to say everything there is to say about them. But as I begin, I just want to note some of the similarities and differences between fatigue problems and sleep problems. Sometimes they're related, sometimes they're not. So they're both what I think of as mind-body syndromes, meaning that they both have psychological causes and as well as physical causes. And some of the treatments or some of the things we're going to talk about that can improve them are both going to address mental or cognitive parts as well as physical or medical components. They're very common during treatment. It's difficult to get through most cancer treatment without having some fatigue and some sleep problems, if not both. But they also persist after treatment is over, and that's what I'm going to focus on today. And they all benefit from similar interventions. So you'll hear me say the same things over and over a bit because both fatigue problems and sleep problems will benefit from medical assessment, benefit from exercise, education, cognitive behavioral therapy, which Dr. Walsh just gave us a great introduction to. So you'll hear me say some of the same interventions, but also some differences as well as we talk about fatigue and sleep. One thing I want to get to say straight out is that being sleepy is not the same as being tired. And this gets very confusing when we talk to our doctors or our doctors and nurses talk to us, because in English, not in all languages, but in English we say I'm tired to mean both. And that's a big problem, because sometimes we're tired and we're sleepy, which is great because we can go to bed and get a good night's rest. And sometimes we're tired and wired, and we are really tired and we can't sleep, and that stinks. And yet we say I'm tired for both. So I'm going to try, catch me if I slip, to say tired for fatigued and sleepy for sleepy, because they are very different. I also want to point out as we go through, as I talk a little bit more about fatigue and sleep, is some of the things we do to try and help ourselves when we feel fatigued and help ourselves when we can't sleep actually are a little paradoxical. The things we do to try and make us feel better often make our symptoms worse. Some of the things are good short-term cures, but they're bad long-term cures. So if you have problems with fatigue and insomnia after your cancer treatment, you may have to stop doing some of the things you thought were the right things to do, or the things that feel good on day 1, but they actually make your problems worse on day 4 and day 5, and I'll talk more about that. And finally, I just want to point out, obviously I'm not giving you medical advice about what to do. This is a general education overview. The suggestions I'm giving are going to be very different for different people depending on your treatment, depending on what else is going on in your life, what other chronic conditions you may have. So these are all ideas to generate for you to think about and for you to talk with your care providers about. So let's start with cancer-related fatigue. Cancer-related fatigue is a persistent sense of tiredness or exhaustion. It's not proportional to activity, meaning it doesn't come on because you run 5 miles and then you're tired. And it doesn't respond well to rest, so even when you rest, the fatigue doesn't go away, and it interferes with your usual functioning. About 80% of patients during treatment get this kind of cancer-related fatigue, and about 20 or 30% of survivors still have this kind of fatigue a year after treatment is over. So the good news is, for most people, the fatigue subsides over time, and I'm really going to focus on the folks who are still having it after their treatment is over. What survivors often say to me is they just can't believe how fatigued they are, and they will say things like it persists, like it's still here, like 6 months after my treatment, or 8 months, or 6 years after my treatment. It's really puzzling to them. It's not driven by exertion, as I said. So they say, I haven't done anything, and I'm still tired. It doesn't improve with rest. I sleep and I get up and then I still feel tired afterwards. It often feels very profound or total. It's really different than the kind of fatigue our friends have or our neighbors had, or maybe we had when we were younger and we played basketball or we ran around with our kids. That it's not everyday fatigue. And if you have this, you know someone who has cancer-related fatigue, you know what I'm talking about. So how do we manage fatigue? I'm going to talk about 4 different approaches. Medical evaluation, getting some education, which hopefully we're starting today, reconditioning your body, and managing our minds. I could probably say reconditioning the mind too. Basically being aware of how thoughts and feelings can increase our fatigue. So in terms of medical assessment, this is crucial for fatigue because fatigue is a symptom of many medical disorders. There are many medical problems. There's a long list there. I'm not going to go through it. You may be having fatigue not because you're a cancer survivor, but because you have a medical condition. So it's critical that you talk with your doctors about it and you tell them how bad it is and make sure they listen. Because they need to know you have this. If you're having this intense, persistent fatigue that doesn't get better from rest and is not driven by exertion, they need to hear those symptoms from you so they can start thinking about what medical condition may be involved. I highlighted medications because there are medications that can cause fatigue as a side effect. Some people after cancer treatment are on some medications for cancer prevention. Some of those things can have fatigue as a side effect, and that's very difficult. But you need to talk with your doctor or your practitioner who's prescribing whether there can be changes in medication, changes in dose of medication, changes in timing. There may not be. You may have to work around some of these symptoms, but it's important that you talk with them about it if you're having that significant level of fatigue. Probably for people who have cancer-related fatigue, one of the most effective things is to address physical reconditioning. We don't know all the reasons that people have long-term cancer-related fatigue, but we suspect that for many people, the major problem is physical deconditioning. So when you're fatigued, it's a normal thing is to rest and conserve energy. It's a great short-term solution. Unfortunately, it's a bad long-term solution because the more you rest, the more your body loses fitness. You lose muscle mass, you lose aerobic capacity. And so if you have a treatment that lasts 6 weeks or 6 months, or I work with patients who have treatment that lasts 2 years, they often end that treatment in a very deconditioned state. They've lost muscle mass, they've lost physical endurance. And so ordinary activities are going to feel difficult, and it's going to make them feel fatigued. And then what are they going to do? They're going to rest. And then they're going to feel worse. And sometimes when I talk to patients about, they'll say, oh, well, my nurse at the clinic, she said when I was tired, I should rest. And I say, yeah, but she meant that 2 years ago when you were getting radiation, buddy. It's not the same anymore. So sometimes I think as providers, we give people short-term information that doesn't help them in the long term. So what do? Fortunately for me, and even more fortunately for you, there's a physical therapist who's going to address, I hope, some of these issues. There he is. So I'm going to go through this pretty quickly. try anyway. Slide. No, there we go. So if I told you I were having a hip replacement in a couple of months, let's say, and I said my plan was I'm just going to lie in bed for 3 or 4 or 5 weeks and wait till all the pain goes away and everything's healed, and then I'm going to get up and walk, you would tell me I was crazy. Because we all know if you have a hip replacement, you've got to do rehab, man, or you're going to be in a lot of trouble. That's true also for a lot of cancer therapies, again, depending on what the treatment is. When you think about dealing with fatigue, I talk with patients a lot about this kind of rehabilitation approach. If you don't do any physical activity and you're resting, you're not going to build up more endurance and more capacity. If you do too much, if you think you're going to go run 3 miles, because that's what you did 10 years ago, 20 years ago when you were in college, and then you can't get off the couch for a week because you're exhausted, that's not good either. You need to focus both mentally and physically in this rehab zone. So what can you do? You can really start gradually. I'm not an exercise physiologist or professional. I talk with patients about, can you walk for 5 to 10 minutes comfortably? And if you can, maybe that's something you should do. Maybe you should start there. You need to have realistic expectations. And if you can't walk for 5 or 10 minutes, or you have difficulties, you need to get some professional advice from a physical therapist or other professional who can help you begin to do this kind of exercise program. You need to do it, but not overdo it. And that's hard. A lot of patients I see are either not doing it, so they're lying on the couch, or they're walking a little bit and saying, oh good, I took a walk, but they meant from one side of the room to the other. Or there are people who say, I'm going to do, 6 hours of activity at the gym, and then they fall apart and they're exhausted. They see I'm too fatigued, I can't do anything. It's tough. You've got to stay in that rehab zone. Oops. So the other thing I talked about with fatigue is managing the mind, and that really means being aware of how our thoughts can get away in our best intentions. We have a lot of worries about health, worries about how other people view us, things we think we should do, and sometimes those thoughts kind of take over and they drive the bus. Even though we want to do one thing, those thoughts push us in a different direction. And there are strategies, and some we heard about just earlier, to try and regain control of those thoughts and feelings. I'll give you an example. So this is an example I feel a lot about. This is a hypothetical person. This is Mary's dilemma. She feels very isolated at the end of her treatment. She feels kind of alone. Her friends invite her to go shopping and have dinner. And then it begins. What if it's too much? I'll slow them down. I'll be embarrassed. They'll wish I weren't there. I won't be able to do it. I don't need to tell you because you've either had these thoughts or you've heard them from your friends. So Mary stays home. She feels sad. She feels sort of regretful. She feels more isolated, probably more fatigued and more depressed. And her friends now aren't really sure if they should keep inviting her or if they shouldn't invite her so much. This is exactly what Mary didn't want to have happen, but those thoughts got in the way. They drove her in exactly the opposite direction than she wanted to go. So what can you do? There's lots of things you can do. One thing I often suggest to people is think about how would you talk to a friend? How would you coach someone else? We're much better with our friends than we are with ourselves. You can question some of those assumptions. You can pick doable goals. Maybe she could just go shopping and not go to dinner. Maybe she could go to lunch. Maybe she should tell them, I'm not sure I can do all that. Would you be able to drive me home if I get tired in the middle? There's lots of ways out of that dilemma that Mary felt that she was in. I'm going to speed up a little bit because I think I'm taking too much time. So the other thing, another intervention that's helpful for cancer-related fatigue are mind-body kinds of approaches, yoga, tai chi, mindfulness interventions. It's not surprising because they involve some physical activity as well as some mental clarity. So these approaches can also be effective. Stimulant medication, some people have tried or heard about stimulant medication. Unfortunately, once therapy is over, stimulant medication is actually not that helpful for cancer-related fatigue. It's something that used to be tried a lot and is sometimes used for people on treatment. So if you're during cancer treatment, stimulants can be used. But for survivors who are after the treatment, stimulants are actually not usually that helpful. Cognitive behavioral therapy, we heard about a few moments ago. There are specialized versions of cognitive behavioral therapy adapted specifically for fatigue, and not surprisingly, they address things like the thoughts that we were talking about, the thoughts that may be fatigue promoting, as well as coping, lack of activity. These are basically structured approaches to try and help people change their physical activity level and change some of their thought patterns. So what are your resources if you have cancer-related fatigue? I didn't fix it in the last few minutes, but what can you do? You need to talk to your medical team, and I mean that very broadly, meaning your physical therapist, your nurse, your doctor, your social worker, your nutritionist. There's a lot of people that can be really helpful here. There are local resources. There are cancer rehabilitation programs in this area. At least Google tells me that there are. There's Livestrong at the YMCA. They're here today. There are national resources, American Cancer Society and Livestrong.org. American Diabetes Association, American Heart Association have online information about how to promote exercise safely. And there are also behavioral health resources, cognitive behavioral therapy, support groups, and individual counseling can be helpful as well. These are a couple of books I think are very helpful for people to get those thoughts to sort of out of their way so they can move forward. One is called The Happiness Trap, and the other is Get Out of Your Mind and Into Your Life. There are many, many books that can be useful, but these are a couple that I recommend. Let me jump now to insomnia and just say that insomnia is also very prevalent in people after the end of cancer treatment. About 30% of long-term survivors have insomnia compared to about 8% in the general population, so it's much more common. And again, sometimes our attempts to accommodate our insomnia can make it worse. So we nap more, we spend more time in bed, we worry about sleep, and we know that's the best way to get to sleep, right? Is to start worrying, will I sleep tonight? That is awesome. So what am I talking about in terms of insomnia? I'm talking about difficulty getting to sleep, staying asleep in the middle of the night, and staying asleep at the end in the morning. So being able to sleep to a realistic wake-up time. Insomnia, we basically say to have a diagnosis of insomnia, you need to be losing 30 minutes of sleep a night. It needs to happen 3 nights a week or more, and it has to happen for a month or more, and it has to have some distress or impairment in functioning. So again, medical assessment is very important. There are medications, there are physical symptoms that can get in the way of sleep. If you treat the symptom, your sleep may improve. And again, medications is another one. It's very important to talk with your doctor and pharmacist about to see if there are ways of adapting or changing medications if they're interfering with your sleep. I'm not going to talk about other sleep disorders because there are many, many sleep disorders. I'm talking about insomnia. One thing that I will just mention is sleep apnea, which many people have heard of, which is difficult breathing while asleep. If a person snores a lot, if they have any symptoms of choking or gasping for air while sleeping, if they have non-restful sleep, you sleep 8 hours and you wake up and you're completely exhausted and feel sleepy, you're going to fall asleep during the day. If you have headaches in the morning, those are all symptoms that you suggest that you may have sleep apnea, and it's important to talk with your primary care doctor about that and maybe be evaluated at a sleep clinic because that is a significant medical condition. But I'm talking about insomnia, which is difficulty sleeping, and the one symptom I want to talk about briefly is hot flashes. Hot flashes are a common side effect of cancer therapy and some medications that people are on even after their main cancer therapy is over. It's important to talk with your medical provider because, again, medications may be able to be adjusted. If you continue to have hot flashes and they're interrupting your sleep, you can consider paced respiration, or sometimes called paced breathing. It's a specific kind of diaphragmatic breathing. It's usually done 15 minutes a day, twice a day, and also when a person starts to have symptoms. There are apps specifically about paced breathing. You can go to menopause.com. There's some information about paced respiration there. There's also a wonderful YouTube video called Diaphragmatic Breathing Technique. If you put that into YouTube, you get a very nice animated video that explains diaphragmatic breathing. But More generally, beyond just the medication evaluation, what the interventions are available are education, again, which hopefully we're starting today, medications, exercise, and again, cognitive behavioral therapy. So I'll talk about them quickly. One important thing in terms of education around insomnia is to understand what your sleep needs really are. In my experience, many patients who come to me with insomnia, one of the difficulties is they think they should be sleeping more than they turns out that they do. So if you need 7 hours of sleep a night, that's what would make you feel good, but you think you need 8, you're going to have an hour of insomnia every night because you're trying to feed yourself 8 hours of sleep, but your sleep need is only 7 hours. You can't make yourself sleep more than you need to. So it's important to understand that. It's important not to think that short-term lack of sleep is a catastrophe, and also to differentiate between short-term sleep problems and long-term sleep problems. We all have a night every once in a while when we can't sleep, especially if something's on our mind. One thing I say to people often is if you feel rested and ready to go for the day, then you're probably getting enough sleep. So don't think that you have to get 8 hours because the New York Times said everyone needs 8 hours, or you needed 8 hours 2 years ago, or your sister needs 8 hours. You need to be a little bit flexible and see how much sleep that you really need. It's important to remember some older adults may only need 5-6 hours of sleep. That's not that unusual. So sleep hygiene is another part of education. I'm not going to go through this in detail because I'll talk about some resources. But sleep hygiene is a lot of basic information to help your sleep environment, your sleep practices, your sleep timing. A lot of this is things you may have heard about before, but it's important, and I'll give you some resources for that, to get a good checklist and make sure you're doing all these sleep hygiene things if you're having some insomnia problems. Exercise. Again, going to be very helpful. It's part of sleep hygiene, and mind, body, and relaxation training can also be very helpful. There's good evidence that this will help with insomnia as well. Medications, of course, we all know that there are many medications for sleep. They do give people sort of rapid, effective relief, particularly for sleep onset problems, if you have trouble getting to sleep when you go to bed. They have side effects. Sometimes people feel sleepy in the morning. Sometimes people feel sedated. They can have dependence or abuse potential. And a lot of times people tell me they just don't want to take sleeping pills for a long period of time, or their doctor doesn't want to prescribe them for a long period of time. Cognitive behavioral therapy, however, is our friend once again because it is probably the most effective treatment for insomnia. And here you see from the Archives of Internal Medicine, it says that patients generally get greater benefit from cognitive behavioral therapy than from medications. And that's true not only in the general population, but it's also true for cancer survivors. So I'm not going to talk in detail about cognitive behavioral therapy, but there are many, many components in terms of logging sleep and restricting when you sleep and changing your sleep schedule. It's a lot of components that go together to make cognitive behavioral therapy for insomnia. The good news, it is very, very effective treatment. The bad news is it's demanding treatment. People often get less sleep for 1 to 2 weeks. I can't tell you what it's like to be in a room with people with chronic insomnia and tell them I'm going to give them less sleep for 1 or 2 weeks. It's frightening. About 25 to 30% of people who start this kind of treatment drop out because it is unpleasant for a couple of weeks. It's also not appropriate for people who have certain medical conditions. The biggest problem with cognitive behavioral therapy, though, is you can't find it. You can't find someone to provide it. There are very few trained practitioners. Fortunately, there are self-help alternatives. There are 2 online treatments that are cognitive behavioral therapy, which you can access online. One is called Sleepio, and one is called Shut-Eye. I'm not sure if there's any difference between them, though I know Shut-Eye has been, research does show that it is effective in cancer patients specifically. There are also books. There are some excellent books, which if you are a very dedicated and person, and you can make yourself do these book treatments, they are also very effective. I'm going to talk just briefly about resources before I stop. So there are excellent resources from these groups, the National Sleep Foundation, the Society of Behavioral Sleep Medicine, and the American Board of Sleep Medicine. Sleep Foundation in particular has excellent resources for sleep hygiene. So if you are having difficulties with insomnia, that is a good place to go to get information. And I'm going to skip that slide, and I'm going to finish. Thank you very much.